This morning we have Peter Rothpletz presenting on a new drug that helps prevent the transmission of HIV. Peter is a second-time presenter, and as introduced, this subject is kind of controversial, so just make sure that you're asking thoughtful questions, and with being a second-time presenter, you can ask him more clarifying questions as well as go a little bit more in-depth questions. Here's Peter.
So the title of the study we're going to be focusing on today is the prevention of vaginal HIV transmission in macaques by a coitally dependent Truvada regimen. Beautiful title. But it's a little confusing, so I renamed it the application of rectal HIV prevention methods to vaginal tissues. That's still a little confusing, but I promise that by the end of this discussion you're going to be able to fully understand what's talked about in this paper and feel comfortable discussing it with other people. Before we get into it, I want to thank Luke, Mark, Sydney, Amanda, and Claire for putting in essentially a ton of work the last 2.5 weeks, for making sure I understand every single fact and figure in the study, embedding my presentation, every single slide, and making sure that I don't sound like a complete idiot here. So to each of you, thank you very much. And really, before we get into the important part of this presentation, we have to talk about one more thing. And that is sex. One of the most beautiful things about this institution that Mr. D so graciously set up at Pingree is that we're able to talk about mature themes that would normally be too uncomfortable or awkward in a normal classroom setting. And we're able to discuss them here because they're in the name of science, because they're important, because they matter. And so today I'm going to be saying sex. I'm going to be saying it a lot. I'm going to be saying anal and rectal and vaginal. And you know, those words, they bring out our inner third grader, and they make us giggle, and they make us want to laugh. And you know, that's okay for right now, but understand that, you know, this is science, and this is stuff that has incredible real-world implications. And so remember that if you do feel the urge to laugh a little bit, this stuff does matter. And so from there, we need to start our discussion with just a brief introduction to HIV as a disease. And so in the spirit of Sesame Street, let's start letter by letter. H stands for human. HIV is a disease that is passed from humans to humans. I is immunodeficiency. HIV is a disease that targets your immune system. It infects your body, gets into your immune cells, it copies itself, and then it destroys your immune cells until there's nothing left, and then it progresses to its final stage, which is AIDS, when your body can no longer combat foreign infection or disease. And finally, V is for virus, because HIV is a disease that is viral, much like the viruses that give you the common cold or the flu, except HIV, the body has much more difficulty fighting back against HIV. So why do we care? HIV was discovered in 1981, and since then 39 million people have died. That makes HIV the world's 6th leading killer. Beyond that, 35 million people are still living today across the globe with the disease, and more than half of them don't even know that they have it. That means that they're not adapting their lifestyle to living with the disease, they're not taking preventative measures, and so the disease is continuing to grow, and that's dangerous. So clearly, that's why you should all care. Why do I care? This past February, one of my closest friends found out he was HIV positive. He's not even 20 years old, and he's going to have to live the rest of his life dealing with that. And so you can understand why this is a topic that is very serious and also dear to me. There is no cure and there is no vaccine for HIV, but that's not to say that there's nothing that you can do about it. There are 2 specific preventative measures, the first being PrEP and the second being PEP. They sound similar, but they're very different. We're going to be talking about the first, which is PrEP. PrEP stands for pre-exposure prophylaxis. You would take it before increased risk behavior that could lead to HIV infection. This is very different from PEP, which stands for post-exposure prophylaxis, which you would take after a suspected HIV infection, far before symptoms begin to arise. If you have an HIV infection, symptoms begin to arise 2 to 4 weeks after that infection. you would be taking the PEP regimen, again, the post-exposure prophylaxis, 72 hours after that suspected transmission. PrEP, on the other hand, is very different. You're going to be taking that before you even think you have the chance of being exposed to HIV, right around the start of increased risk behavior. The only current PrEP method that's FDA approved and on the market today is Truvada, and that's a combination of two separate drugs, emtricitabine and tenofovir disoproxil fumarate. But for the rest of this study, we're going to be referring to them as FTC and TFV, just because I'm not going to be able to pronounce those two names again. Yes, Mr. D.
Could you just explain like the pre-risk behavior? Give an example of one, just so we understand what you're talking about.
Yeah, of course. So increased risk behavior, that would be casual, anonymous, unprotected sex acts. When you're not using protection, such as some condoms or other sexual protection measures, and you're having multiple partners and you don't necessarily know their medical history. Does that answer your question?
Mm-hmm.
Thank you. All right, so we now know Truvada is this two-drug combination of FTC and TFV. And what the combination is able to do is it stops HIV growth. As you probably remember, HIV is a virus. It gets into your body. It injects its HIV RNA into your cells, and then it uses reverse transcriptase to copy that HIV RNA into HIV DNA, which then grows the virus. What the combination is able to do, again, FTC and TFV, it gets inside your cells and it stops reverse transcriptase. It doesn't kill the virus. It makes it so the HIV RNA that's already in your body can't be copied into HIV DNA, which then grows more virus. Does that make sense? Okay. How effective is Truvada? Well, we have studies that are already done. Strict adherence provides 99% protection against HIV and MSM, or men who have sex with men. It's gay and bisexual men who have sex with other men. But there's a problem with that, because strict adherence is rare. We're all human beings. We have busy schedules, we have work, we have school, we have social obligations. It can be difficult to adhere to a strict policy every single day. You have to be taking this pill. And so the next logical question, is a paracoidal Truvada regimen effective? What is paracoidal? Quite literally means around sex. Would taking this medication, not on a daily schedule, but rather exclusively based on your sex life, still work? And there has been a study about this as well. We found that intermittent Truvada regimens are just as effective as daily PrEP. However, there's another problem, and that's that it was focused exclusively on rectal transmission. And because of that, it doesn't inform us on the efficacy of the drug, of the intermittent Truvada use against vaginal transmission. And now I'm going to explain why. There are differences between vaginal and rectal tissues. And the researchers in this study suspected there were two main reasons why we can't just assume that Truvada will work. The first will be the physiological differences. So in the vagina, there is a multi-layered epithelium of tissue. In the rectum, there is one single epithelium layer of tissue. And moreover, during the menstrual cycle, as you can see in this picture, the epithelial layers in the vagina, they switch in density and thickness. So during the first half of the menstrual cycle, that top layer of epithelial cells is much thicker. And then during the second half, it's slothed out of the body and gets much thinner, and that's because of the rise in the hormone known as progesterone. And scientists expect that this sloughing of material, this shrinking of the top layer, is what makes HIV infection, at least vaginal transmission of HIV, much easier. The second reason would be the pharmacological difference between vaginal and rectal tissues. And it sort of is similar to the physiological difference, but not exactly. And so what researchers did is they wanted to actually directly address this difference. So in the study, they took 6 macaques, which is a type of monkey, completely separate from the rest of the information that we're going to be talking about today. And they gave them one single Truvada regimen. And what they did was then, in the structured time block, 12 hours, 24 hours, 36, 48, 60, is they measured, using a sponge, the concentration of those two drugs, the FTC and the TFV, in the secretions from both the vagina and the rectum. And what they were able to determine is that the concentration in the Truvada of the FTC and TFV for both drugs was much higher in the rectal secretions than in the vaginal secretions. Does that make sense? Does everyone see that? Okay. And they think, again, they don't know, this disparity is due to an immunological composition difference between vaginal tissues and rectal tissues. So now we can get into really the more important part of the study, and its exact methodology. So 12 pigtail macaques all received weekly SHIV exposure, and 6 received paracoidal Truvada regimens at 24 hours before and 2 hours after their SHIV inoculation. Quick question, what is SHIV? So there's HIV, which we learned about earlier, which is the human immunodeficiency virus. There's SIV, which is the simian immunodeficiency virus that normally infect monkeys. And then SHIV is what we're using here, which is the simian human immunodeficiency virus. As you recall from earlier in the presentation, HIV only infects humans. It's transferred from humans to humans. Likewise, SIV, simian immunodeficiency virus, is transferred from monkeys to monkeys. For the sake of the study, in order to better be able to replicate how this would be transferred in humans, but in an animal model, they took HIV and they modified it so it could infect monkeys. That's what SHIV is. Does everyone understand that? Okay. So let's go over the methodology one more time. 24 hours before virus exposure, the 6 macaques that were receiving the Truvada regimen and not the placebo were given 1 oral dose of Truvada. 24 hours later, they were exposed to their 1 milliliter of SHIV inoculation. It was delivered non-traumatically via a sterile gastric feeding tube, and then 2 hours after that inoculation, they were given once again 1 more regimen of Truvada. And this is what they found. The Truvada-treated macaques survived. Now this is a survival curve, but don't be fooled. It says % survival right here on this axis, but that's not actually, it doesn't mean every single shark decline in the red dotted line. It's not actually one of the macaques dying. It's just the first time that they're testing positive for HIV. So what you can see is the top line, the blue line, are those 6 monkeys that were all treated with Truvada. Yeah?
Just to clarify, this study had 1 single infection?
No, I'm sorry. It was weekly.
Okay.
So once a week for 18 weeks, they were given this regimen. Right. So 24 hours before virus exposure, 24 hours afterwards, they're given the SHIV inoculation, 2 hours afterwards. Repeated weekly for 18 weeks.
And then the controls didn't get Truvada?
Correct. They received a placebo. The 6 monkeys that were given the Truvada did not test HIV positive for the remainder of the study, all 4 months. And those that did steadily all read positive for HIV over the course of the study. And so what researchers were able to conclude is that intermittent Truvada can protect against vaginal SHIV. There's one more thing that they wanted to test, though, and that's whether the menstrual cycles interfered, or rather prevented, the efficacy of Truvada. And so what this is here is, it's a little bit much, so it can be confusing. These are 4 monkeys. The 2 on the left are monkeys that received the placebo, and the 2 at the right are monkeys that were exposed to the Truvada regimen. And what this is measuring is the level, or the concentration rather, of progesterone in the body. If you recall, progesterone is the hormone that is weak during the first half of the menstrual cycle, and then is stronger during the second half of the menstrual cycle. And again, it represents that epithelial sloughing from the body, which during the second half makes it easier for HIV infection. And so what this is able to prove is that 4 complete menstrual cycles took place, and Truvada was still effective. So it wasn't like the monkeys were given Truvada and then somehow it interfered with the menstrual cycle, so you didn't see that lining, and so it was effective, but it wasn't really like the menstrual cycles were continuing. The menstrual cycles were still continuing. Truvada didn't interfere with that, and the menstrual cycles didn't interfere with the effectiveness of Truvada. That's what this represents. Yes,
And
Andy?
do each of those 4 graphs represent a different monkey?
Yes, different monkey. There were 12 in total. Just for the sake of space on the screen, I only showed you these 4. And so now we have to ask, why does this matter? And it matters for a couple reasons. The main of which being less frequent drug administration. For individuals who are exposed to this increased risk behavior who are going to be taking these drugs, decreased administration means a lot. First of all, it's reduced cost. They're not going to be paying nearly as much to get their hands on these drugs, which means it just motivates them more to go out and get them. And second of all, it's reduced frequency of side effects. If you're only taking a Truvada regimen, say once a week, once every 2 weeks, that's going to be once a week or once every 2 weeks for side effects as opposed to every single day, which is hugely significant. But of course, this is not the final step. Next, what researchers have to do is take this study and compare it within a human model, a high-risk model. And then even after that, assuming that it does work because it worked well in an animal model, you then have to look at the acceptability of a drug. Because just because a drug works on a biological level doesn't mean it'll actually work in a society, just because it has to be actually picked up and used by those that it's targeted for. And what remains to be seen is whether these individuals that it's meant for will be able to, both able and willing, to use this drug and to be able to predict when the sexual activity they're going to be having is going to take place in order to take this and protect themselves. Thank you.
Just to clarify something, we went over in the data. The thickness of the vaginal wall was something they wanted to examine. They wanted to examine the relationship between the thickness of the vaginal wall and the transmission of HIV. So this study did not specifically look at that. So we don't have any significant information on whether it's easier to get HIV at different vaginal wall widths.
What are some of the side effects of the drug?
Wasn't discussed in the paper. Yes?
Peter, just a couple of clarifications. The first one is, we don't have a vaginal wall, just to kind of clarify what Mr. D said. There is a vaginal lining, and it's called the endometriosis, and that's what's lost during each monthly cycle. Secondly, at the very beginning of your talk, you talked about symptomology starting at 2 to 4 weeks after exposure. Most people don't experience that. They undergo that risky behavior and not even know that they're infected. They may not know they're infected for 6 months, up to 10 years afterwards. So in terms of kind of assessing your behavior, you need to know and recognize that what you just did was probably not safe.
Peter, maybe you just want to explain how they determine the HIV. It wasn't by behavior.
I'm sorry.
How did they determine that the
How was the diagnosis made that they had HIV?
How is it just taking rectal, vaginal, and rectal and vaginal secretions and also blood plasma and testing it using a PCR method?
So they would look at viral load.
Yes.
Is that what you were asking?
Yeah, absolutely.
But can Truvada, like, if you take it at like correct frequency, if the person does have sex with someone who had HIV, won't the HIV still be in their blood? It just won't be able to replicate.
Correct.
And so if you stop taking Truvada, will it flare up?
Yes. That's possible.
Were there any studies done on the efficacy of the drug with the amount taken?
That was not discussed in the paper.
Like, you talked about like the 24 hours before and 2 hours after. Would like different timings make like a difference on?
Wasn't discussed in the paper.
The thing, so since it blocks the replication but it's on the bloodstream, you can still transmit the disease from person to person or function because you don't disease is progress in your body, right?
That's correct. Even with a strict adherence policy, when you're taking it every single day, it's only 99% effective. It's still possible to transmit the disease. Any other questions? Yeah.
You said that even though it's not replicating, it's still in the
bloodstream, and that it can flare up after you stop taking PrEP. But like, if I understand correctly, those HIV cells are still dying off over time. So the reason it is effective is that in many cases, they won't be able to replicate or rate to survive for a long period of time.
I believe so.
Okay.
No.
I think a couple things there. HIV isn't a cell, so it doesn't have like a typical lifespan of like a normal human cell does. So that might be. Where's that? Does that make sense? It can lay dormant.
Okay. Because what I know about the drug is, or from what I have read about the drug, you don't have to be taking it like every day for the rest of your life to suit your high risk exposure, right?
You're saying, can you stop taking it after you're high risk? After you've
After
reduced your high risk,
Yeah.
you're down to low risk. Oh, that's really the question.
Wait, have you been exposed to HIV?
Yes.
I think he's saying at high risk, you were exposed. Oh, sorry.
Like in the question you're phrasing, Mark was saying, are you saying after being exposed?
Yes,
to
after exposure, like after the drug, you don't have to continue taking the drug indefinitely for the brand.
I don't know. Any other questions? Tom? Or,
Just inhibiting reverse transcriptase and any effects on like other systems in the body.
wasn't discussed in the paper. Yeah, Jessica. HAART. I'm not aware of that.
Oh, there may just be a difference there.
Yeah. Might not be approved by the FDA yet, but there are multiple other therapies out there.
So he's just being really, really careful right now. I don't know if you guys can tell this. He's sticking very, very specifically to the information in the study. We want to make sure that we're not propagating any incorrect information right now. So while he does know more than he's saying right now, he suspects several things, but he doesn't want to discuss them because he doesn't want to put out any incorrect information.
All right, thank you.
Next week is Catherine.
Yeah.
Catherine, and Catherine, want to explain what you're talking about?
What?
Want to explain what you're talking about?
I'm talking about a new way of discovering antibiotics. So come out.